I'm Andy Davies from the University of Southampton, and I'm Professor of Hematological Oncology. So I'm going to talk about how we may augment therapy in frontline diffuse large B-cell lymphoma, and perhaps look at some of the abstracts at ASH that are being presented this year. So I think, interestingly, first of all, from the Nordic lymphoma group, there's a stratification of frontline therapy according to biological risk factors. So high-risk disease was defined by biological features such as a MYC translocation, loss of P53 or 17p, double expression, etc. And those patients who had biological risk factors had augmented therapy after induction R-CHOP chemotherapy, had dose-adjusted EPOC with some high-dose cytarabine, whilst those patients who didn't have high-risk features had CHOP with etoposide, as is their standard of care. It was really interesting to see that in those patients with biological risk factors, that this augmented frontline therapy brought up the prognosis of that group of patients. And indeed, it even looked as if intensification of chemotherapy could overcome some of the intrinsic resistance from P53 mutations. So really interesting abstract about giving more chemotherapy. But, we've been looking, haven't we, over the years of adding novel therapeutics to R-CHOP chemotherapy to see if we can improve outcomes. And this year, on behalf of the NCRI group, I've been going to be presenting an update of the Remodel B study. And we asked the question in diffuse large B-cell lymphoma, first of all, could you do gene expression profiling for molecular classification in real time? Was that going to be clinically feasible? And actually, if we looked at the subgroups, could we see if the addition of bortezomib to R-CHOP chemotherapy could improve outcome? And of course, our hypothesis was, given that the sort of multitude of mutations in the NF-kappa B pathway that we see in ABC type DLBCL, that the bortezomib may have an impact upon that group of patients. So we initially reported the study roughly with about 30 months of follow-up and didn't demonstrate any difference, although there was a trend that was non-significant in the ABC subgroup to the addition of bortezomib. We now present data at 5 years, so a minimum follow-up for surviving patients of 5 years. And for the GCB subgroup of patients, there's absolutely no difference in progression-free survival and overall survival from the addition of bortezomib to R-CHOP chemotherapy. But for patients with an ABC phenotype, there's a significant improvement in both progression-free survival and overall survival from the addition of bortezomib to R-CHOP chemotherapy. So at 5 years of follow-up, we see a 15% absolute improvement in progression-free survival and a 13% absolute improvement in overall survival in the ABC subgroup. And really that comes with no additional significant toxicity. There was perhaps a little bit more neuropathy, but that was grade 1, grade 2, etc. in the bortezomib treated patients. We also looked at a group of patients called molecular high-grade lymphoma, which is a subgroup of GC with an aggressive clinical and biological phenotype. And these patients had a significant improvement in progression-free survival from the addition of bortezomib, but the improvement in overall survival was not significant, but the numbers were pretty small. So I think this is a really interesting proposition to say that in molecular subgroups of diffuse large B-cell lymphoma, the addition of bortezomib may potentially improve both progression-free survival and overall survival. So it's great that we had the opportunity to present this data, but we're also presenting some data from the UK group looking at the addition of acalabrutinib to R-CHOP chemotherapy in the frontline study. And this is the update of the ACCEPT study. And we recognize that we see excellent outcomes in terms of response rates and durability of response in this phase 1b/2 trial. And actually, what's important is that there's no difference in dose intensity of the R-CHOP chemotherapy in older and younger patients. So the addition of acalabrutinib to R-CHOP chemotherapy is safe. The outcomes look very promising, and we're now exploring that in a randomized study in the UK. So what else do we see in terms of additional drugs in diffuse large B-cell lymphoma to R-CHOP chemotherapy? Well, actually, there's some really interesting data from Max Top about the addition of glofitamab the bispecific antibody to R-CHOP chemotherapy. Relatively small study, but very interesting. All patients had one cycle of R-CHOP chemotherapy, and then they went on to have R-CHOP with the addition of the bispecific antibody. And response rates are high, as you expect in this kind of study. The CR rate was 76%. The overall response rate was, I think, 93%. And short follow-up, but the responses were durable. But what was very interesting was because these patients were initially debulked by a single cycle of R-CHOP chemotherapy beforehand, actually it turned out that the rate of cytokine release syndrome in patients who went on to go and get the bispecific antibody from cycle 2 onwards actually was really very low. So it's a nice way of being able to debulk patients before you add your additional chemotherapy. So I think some exciting and some interesting innovations, and I think still much to do in terms of exploring additional agents with R-CHOP chemotherapy.